Hi Aarti, how are you?
Hi, fine. How are you?
Fine, thank you. How are things in? You are in Mumbai or you are in Surat?
Surat, Gujarat, sir.
Gujarat, okay. How are things in Gujarat? Things doing well?
Yes,
How,
right.
how are the rains? Have the rains reached Gujarat? Have the rains monsoon has reached Gujarat? Kerala is having a lot of rains.
Not started yet, sir.
Not yet started. Okay. Okay, we'll start the program. Okay, what shall we have today? Case discussion. Dear students, good evening to everybody. Shall we have a case discussion or would you like to have spotters? Students? No response? Like to have spotters or case discussion? Okay, we'll go for a case discussion. Okay, any volunteers to discuss the case? I want a volunteer to start the case. Anybody who would like to discuss the case? Preferably somebody is who is about to appear for the examination. Third year DM students or DNB students. Any student who would like to discuss the case, I think you should come forward to discuss the cases because case discussion is the best method to gain confidence. Then you can perform well in the examination. You can answer questions confidently and also come to a proper diagnosis also. So case discussion, always those who volunteer, they definitely perform very well in the examination.
Sir, I will discuss, sir.
Okay. You are Agnath?
Yes, sir.
Okay, right, fine. So you can discuss. Let me.
Shall I start, sir?
Wait. Let me make it. Okay, right. Now you can start.
Good evening to all. Is 28 years old male IT engineer, complain of exertional palpitation since 6 months, retrostomal discomfort on heavy exertion since 4 months. So, history of present illness. Patient started experiencing palpitations on exertion, especially on usual heavy exertion for the past 6 months. No history of palpitation at rest. History of regular fast palpitation. No history of breathlessness, giddiness, syncope, or chest discomfort associated with the palpitations. No history of PND. He feels that his symptoms has come down recently. However, for the past 4 months, he started feeling a mild heaviness in the central part of chest on heavy exercise, which was promptly relieved by stopping the exercise. He stops exercise as soon as he feels this sensation. He says that recently these symptoms has worsened, no history of rest pain, no associated symptoms like palpitations, giddiness, or breathlessness. On few occasions, he had sweating associated with the chest discomfort. He has so far not taken any treatment, no history of hemoptysis, edema of legs, or abdominal distension. Past history, past history of rheumatic fever, not a diabetic or a hypertensive, no history of detection of the heart disease in childhood. Family history, both parents are alive, father no illness, mother is diabetics, no younger, one younger brother is healthy, habit, no smoker, teetotaler, heavy,
Teetotaler,
healthy life.
he does not use alcohol.
Okay. Healthy lifestyle, regular exercise.
Okay. So from the story, what are the, can you draw any conclusions or you think that the story is very vague and very mild, so you cannot draw any conclusions.
Sir, actually, patient is having their exertional palpitations.
Hmm.
Means he must have some regurgitant lesions, sir.
You cannot say use the word regurgitant lesion. You can say volume overload.
Volume overload, sorry. So volume overload lesion.
Volume conditions. Usually, palpitation is associated with volume overload. Volume overload has two groups of diseases. They are
regurgitant shunt lesion.
yeah, regurgitant lesions and shunt lesions. So ASD, VSD, PDA, all can have palpitation as a symptom. And of course, regurgitant lesions also can have palpitation as a symptom because of the volume overload. Okay, right? Yes.
Yes. Sir, he is also complaining of the retrostomal discomfort on the heavy exercise.
Yeah. He's 28-year-old male. So what do you think can be the retrostomal discomfort on heavy exertion if you think that this is a history which may indicate some degree of ischemia? We do not know because it's occurring only on very heavy exertion. So
Yes,
what
sir.
are your possibilities?
Discomfort on heavy exercise. It could be
coronary artery disease.
Could be coronary artery disease, sir.
Yeah, I think you should always consider because even though 28-year-old male engineer who does not have any other illnesses, who is leading a healthy life, his chance of developing a atherosclerotic coronary artery disease at this age is very, very low. But IT people have got a lot of stress and strain, and they overwork, and sometimes they work in odd times. So there is a possibility that he can develop a premature atherosclerosis. So you should definitely think that is a possibility. Yes, very good. Yes. What else? All others can also join. If there are some suggestions, you can always give your opinion. Egnath, do you have any other thought?
Sir, actually, we can also consider the aortic regurgitation, sir.
Yeah,
because after heavy exercise, again that afterload get decreased and that diastolic flow decreases, and also the coronary perfusion that during
what happens
diastole
to in a patient with aortic regurgitation when they exercise? What happens?
Sir, actually, during exercise, AR get decreased.
Yeah, AR becomes less because of the decrease in the diastolic phase. So the AR becomes usually patients with AR they tolerate exercise extremely well. So very unusual for them to develop symptoms unless they develop the LV dysfunction and exertional breathlessness. Retrostomal discomfort on heavy exertion in aortic regurgitation is not very common. Aortic regurgitation can give rise to chest pain, nocturnal chest pain. That is the classical symptom of aortic regurgitation in relation to the ischemic cardiac pain. But I will give I definitely I would like to consider aortic regurgitation also a possibility, but not high in the list.
The patient had left to right shunt and now patient has developed pulmonary arterial hypertension.
Okay.
And sir, anomalous origin of the coronary artery.
Okay, anomalous origin of the coronary artery is a possibility where there is a good communication between the anomalously originating left coronary artery and the right coronary artery. And now he has grown, and while exercising, he is developing some symptoms. So, anomalous origin of the coronary artery, which is anastomosing, and so that providing blood supply from the other coronary artery, I think it's a possibility. Yes. What else?
Sir, hypertrophic cardiomyopathy.
Yes, I think that's a very important diagnosis we should have considered. Hypertrophic cardiomyopathy, 28-year-old male complaining of some heaviness on exertion, you must always consider. Then how can you explain exertional palpitation?
Yes, sir. Sir, patient may be having ventricular arrhythmias. Or sir, patient is having mitral regurgitation together.
Very good. These patients with hypertrophic cardiomyopathy can have mitral regurgitation, and also some of these patients can develop arrhythmias on exertion. So arrhythmias on exertion and mitral regurgitation both can contribute to symptom of exertional palpitation. And he also gives a history of history of regular fast palpitation. So there is a possibility that he might have had either atrial arrhythmia or sometimes even short spell of ventricular arrhythmia, which may be secondary to his basic disease process. That is hypertrophic cardiomyopathy. Very good. Hypertrophic cardiomyopathy is a possibility kept to be high in the list. What else? And also exertional discomfort on AVX. So these patients with hypertrophic cardiomyopathy sometimes
Dilated cardiomyopathy also, sir, we can think about.
yes, very good. Dilated cardiomyopathy also can be a differential diagnosis. Why?
Sir, because sir, patient is having exertional palpitation.
Okay.
Sir, dilated cardiomyopathy usually associated with mitral regurgitation.
Okay, very good.
Sir, with the exercise, so they get even sinus tachycardia, as well as sir, sometimes they also get the ventricular arrhythmias.
Very good. Only problem is that his symptoms are only on heavy exertion.
Yes, sir.
Patients with dilated cardiomyopathy, by the time they start develop significant symptoms, including arrhythmias, especially ventricular arrhythmias, there usually ejection fraction, LV dilates, and all those things would be there. So we can definitely consider that as a possibility, but slightly on the lower in the list.
Sir, we can think about the aortic valve disease having both, sir, regurgitation and the stenosis, like, sir, in cases of bicuspid aortic valve.
Okay. So how will you explain symptoms? Aortic regurgitation will explain the exertion palpitation, and chest discomfort can be related to his aortic.
Yes, sir.
Very good. That is a good possibility, especially in
And
patients. But
so
very
one
often,
more disease of congenital, sir, which is associated with both stenosis and regurgitation, is sub aortic membrane.
okay, so membrane can be associated, but usually the aortic regurgitation of subvalvular membrane is usually not very severe, but usually mild. So,
yes.
but that both can be considered, because what is the mechanism of aortic regurgitation in fixed subvalvular membrane obstruction?
Sir, in case of subaortic membrane, sir, the jet of the flow from LV to aorta, it damages the aortic valve.
Yeah, so the obstruction is below the aortic valve. So the stenosis opening also is below the aortic valve. The high velocity jet through their stenosis can impinge on the aortic valve and sometimes damage, not sometimes, it can damage the valve, and these patients can go for aortic regurgitation. It is considered that almost 80 to 90% of patients with subvalvular membrane will have associated aortic regurgitation. But that aortic regurgitation is not severe, that's all. Okay, right? Yes.
Sir, can we think about coarctation of aorta and, sir, hypertensive heart disease or aortic valve involvement with coarctation of aorta?
Only thing is that he does not have any symptoms related to any coarctation, like cough, muscle,
claudication,
or none of these things is there. So we cannot directly think, but of course, coarctation of aorta may be associated with the bicuspid aortic valve. They can have some degree of aortic stenosis. So coarctation of aorta also can be one of the differential diagnoses that we can think about. Yes. Any other possibility? Anybody else? Nobody else is giving any differential diagnosis. Saroj is always very active. So anybody else who would like to give some other thought process?
And now we have to think about right side of the heart, sir.
Okay.
Sir, like, sir, can it be, sir, some type of ARVD or restrictive cardiomyopathy?
RVD, of course, it can explain the exertional palpitation, all those things. But retrosternal discomfort, how will you explain?
Sir, yes, sir. No, sir.
Do you think that this could be just a muscle bridge?
Yes, sir. Muscle bridge, sir. Yes.
Large muscle bridge, which can, how does the muscle bridge cause symptoms? How can it cause symptoms?
Sir, exactly, I'm not knowing, but sir, most probably, sir, due to the contractions, sir, the diastolic feeling, sir, during the systole, the bridge causes very significant contraction and ischemia in this arrhythmia.
Okay.
No.
You see, the muscle bridge, if a large muscle bridge, it squeezes the coronary artery. Mostly the LAD is the one which is mostly affected. It can give rise to severe QC effect. And even though the diastolic filling is the most important part of the coronary filling, the superficial coronary, the epicardial coronary arteries actually fill during systole. But the intramyocardial as well as endocardial vessels fill during diastole. So the coronary perfusion is actually during diastole, but if there is a poor ventricular systolic filling of the epicardial coronary arteries, then the diastolic filling also will be impaired. So in patients with large muscle bridge, sometimes the squeezing effect of the muscle bridge on the coronary arteries can interfere with the systolic filling of the epicardial coronary arteries, and consequently it can reduce the myocardial perfusion. So large muscle bridge also is a possibility, and symptoms develop during heavy exertion, because during heavy exertion the squeezing effect of the muscle bridge becomes more prominent, resulting in less of coronary filling, especially during systole, and that can result in less of coronary filling during diastole, and that can result in the symptom of ischemia. So a large muscle, and a very healthy 28-year-old male, an engineer, having very mild vague symptom, you should always think of the possibility of myocardial bridge also. Okay, right? Yes. Any other condition?
Sir, like left to right shunt with dilated pulmonary artery, which can cause discomfort, sir.
Yes, very good. It has been described that sometimes when the in patients with Eisenmenger, or due to some reason, or primary pulmonary artery hypertension, when the coronary, the pulmonary artery is hugely dilated, it can press upon the coronary artery and sometimes can give rise to symptom of ischemia. Very good point. Excellent point. Yes. But it does not have other symptoms. If the patient had severe pulmonary artery hypertension, we would have expected other symptoms like significant exertional breathlessness. None of these things are sometimes even exertional graying, exertional blackout, or loss of syncope. None of these symptoms are there, so we cannot keep pulmonary artery hypertension very high in the list. Okay, yes. Any other possibility anybody would like to suggest?
Mitral valve prolapse.
Yes, mitral prolapse can also be considered. Sometimes patients with mitral prolapse can have exertional palpitation, and they can have retrosternal vague discomfort, which has been described in patients with mitral prolapse. What is the mechanism of this retrosternal discomfort? Or sometimes many of these patients can have non-specific chest pain also. What is the reason which has been postulated for this non-specific, or sometimes even this type of chest pain?
So due to prolapse, and there is a stretching of the chordae.
Very good. So
sir, patient can have chest discomfort.
Yeah, you're right. When there's a prolapse, it causes a stretch on the attached chordae, and the chordae pulls on the papillary muscle, and the region where the papillary muscle is inserted, there can be pull on the myocardium, and that has been explained as the cause for chest pain in patients with mitral prolapse. So mitral prolapse is something which you should definitely consider in a person young age, exertional palpitation, and having retrosternal discomfort. Very good. Excellent.
One more thing, though it is male, so can we think about the Takayasu?
Yes, Takayasu should definitely be considered, because young individual coming with Takayasu can always involve the coronary arteries also, and they can have systemic hypertension. So even though male as a not high, very high in the list, you can definitely consider Takayasu aorta arthritis, which can result in coronary artery involvement. It can give rise to aortic regurgitation. It can give rise to sometimes mitral regurgitation also. All those symptoms are possible, and the Takayasu aorta arthritis also is a differential diagnosis. Very good point. Yes. Any other possibility in your mind? Okay, I think we have discussed a lot of possibilities. Now Eknath, would you like to categorize these possibilities in the order of the importance according to you?
Sir, one thing I would like to first is the volume overload state, sir.
Okay.
Okay, and then second thing,
No, volume
hypertrophic
overload is
cardio-
only you are considering the pathophysiology. That is not enough.
Yes,
You
yes.
have to come to the disease process as the diagnosis. So we have discussed a lot of diseases. We have discussed
Yes.
whether chest pain could be due to. We said it can be due to
Yes.
many reasons, including aortic regurgitation. Then we thought of mitral prolapse,
HCM first.
HCM.
Sir, yes, hypertrophic cardiomyopathy first, sir. Then volume volume overload.
Cardiomyopathy must be given a very high priority.
Yes,
A young individual coming with
yes.
these symptoms, that's a possibility. Okay, yes.
Second, in volume overload, I will give prior to the mitral prolapse, sir.
Mitral prolapse also is a very strong possibility because of the
Yes.
mitral prolapse can give rise to both these symptoms. Very good. And
Yes.
symptoms are not very severe also. So I think
Yes.
mitral prolapse can be considered as a strong possibility. Yes, very good.
Then, sir, dilated cardiomyopathy low list because patient is not.
We cannot keep it very high in the list because the cardiomyopathy we would expect the exertional breathlessness as an important symptom.
Yes, sir. Then actually, the ischemia
Yes,
we
I
can
think ischemia also should be, because any patient coming with a retrosternal chest pain on exertion, I think you should always consider, irrespective of the age, you should, because he may be having familial dyslipidemia and he may be having a premature atherosclerosis. So that possibility should always be kept in your mind. Okay, yes, very good. Yes. And any cause for dilatation of the pulmonary artery hypertension, which can also encroach upon the coronary arteries, can give rise to symptom of palpitation, both.
Palpitation.
Yes,
both.
and Saroj just said Al-Kappa. Al-Kappa also can be a possibility. Al-Kappa there are two varieties of Al-Kappa. One which makes a noise and one which does not make noise. Which one is more serious, Eknath?
No, sir. No.
Anybody? Al-Kappa can be two types. One which does not give rise to a noise. Two, the one which gives rise to a noise. For that, you should know what is the reason that there can be noise, means that they give rise to a murmur. What is the mechanism of murmur in Al-Kappa? Do patients with Al-Kappa, do you think that they can have a murmur?
Yes,
or they do not have
continuous murmur.
Yeah, they can have a continuous murmur. What is
with continuous murmur, it will be prognosis will be bad, sir.
Bad, sir. That is it.
Why?
Sir, because sir, the flow is sir from the coronaries, they will be going back into the pulmonary artery. So myocardial will be jeopardized.
There will be coronary still will be there. Sir. There is
right.
coronary venous fistula, we can say, sir. So from the RCA, it is the blood will be diverted to the pulmonary circulation. So the area will be jeopardized, sir.
Okay, those patients with Al-Kappa without murmur, they are less symptomatic?
Yes, sir.
Why?
Sir, until that there is no.
I must tell you that it is the other way around. Patients with continuous murmur, they are less symptomatic. They continue to live to adulthood and they present with symptoms later in life. While the one with no sound, they will develop infarction, they develop dilated ventricle, and they present with heart failure in the early postnatal life. What is the reason? When there is a continuous murmur, obviously means that there is a communication between the high pressure coronary artery to the low pressure coronary artery. High pressure coronary artery is the one which is rising from the aorta, the right coronary artery. The low pressure coronary artery is the one which is coming from the pulmonary artery, which is the left coronary artery. And through this communication between the right coronary artery and the left coronary artery, the left ventricular myocardium, especially the one which is supplied by the LAD, is well perfused and they don't develop infarction. They sometimes can have minor symptoms of ischemia, but they don't go for infarction. While in a patient with no sound at all, that obviously means that there is no communication between the right coronary artery and the left coronary artery. How can the left coronary artery get perfused? Because the pulmonary artery pressure regresses in the early postnatal life. And when the pulmonary artery pressure has already fallen, the coronary filling cannot take place because of the pressure in the coronary arteries, especially the one which is going through the myocardium, is so high that the pulmonary artery, the pulmonary artery pressure is not enough to perfuse the left coronary artery. Then how do they survive? When there is ischemia to the left ventricular myocardium, they develop myocardial infarction, they develop left ventricular failure. When they left ventricular failure, what happens to the pulmonary venous pressure? When these patients develop, when they develop MR, they develop left ventricular failure.
It will increase, sir.
It increases. Pulmonary venous pressure increases. Then what will happen to pulmonary artery pressure?
So it will again increase, sir.
It will increase. And
pH will develop.
They develop pH. When they develop pH, what will happen to the coronary perfusion?
So again decrease, sir.
No, it will increase because
it will improve.
Because when the
pulmonary artery to the left coronary artery,
coronary artery pressure increases, and because of that, the anomalously originating coronary arteries will start getting coronary perfusion. So then the patient becomes less and less symptomatic. So only when the patient has developed pulmonary arterial hypertension, then only these patients can get a coronary blood flow in a patient where there is no communication between the right coronary artery and the left coronary artery. When there is a communication between the right coronary artery and the left coronary artery, there will be a continuous murmur, thereby meaning that they are making a noise. While if there is no communication, no continuous murmur, and there is no noise at all, and these patients actually do very bad. They will have an infarcted left ventricle, the LV dilates, LV pressure goes up, the pulmonary venous pressure goes up, they develop pulmonary arterial hypertension, and that is how they get the coronary perfusion. And then how can the coronary perfusion help in these patients? Because the pulmonary artery has got a venous split. Pulmonary artery has got a venous split. Then how can the coronary perfusion coming from the blood which is flowing through the pulmonary artery can help in oxygenation of the myocardium? What is the oxygen saturation of the mix?
Sir, yes, sir. Oxygen, sir, the extraction from the cardiac muscle is very high.
Oh, yes.
That's why, sir, that much amount of blood saturation will also helpful for the myocardium.
Very good. So what is the oxygen saturation of mixed venous sample usually?
Sir, mixed venous, sir, yes, around, sir, 60.
Oh, 60 is too low. It's usually in a healthy
25.
person. It's about 75, 70 to 75. What is the oxygen saturation of the coronary sinus?
35, sir.
35, very good. So see the peripheral tissues extract only about 1/3 of the extractable oxygen, while myocardium extracts 100% of the extractable oxygen. So in one circulation through the coronary artery, through the myocardium, all the extractable oxygen is extracted by the myocardium, and that is why the coronary sinus has got an oxygen saturation of 30 to 35%, while the mixed venous sample will be around 70 to 75%. So even when the coronary perfusion is from the pulmonary artery, here the oxygen saturation, which may be around 70 to 75, still myocardium can extract plenty of oxygen, and that will be enough to sustain the health of the myocardium, and the myocardium will be able to perform. Because the extraction of the oxygen by the myocardium is much more efficient than the peripheral tissue, and in one circulation, usually the myocardium extracts almost 100% of the extractable oxygen. That is why the peripheral tissues even without increasing the cardiac output, peripheral tissues can increase their oxygen supply by extracting more and more oxygen by the peripheral tissues, because the only 1/3 of the extracted oxygen is usually extracted, and more oxygen can be extracted even by peripheral tissues in case of need. But as far as the myocardium is concerned, myocardium extracts almost 100% of the extracted oxygen in one passage through the myocardium. So that's one important thing you should know in a Al-Kappa. When a patient is coming in adulthood, mostly they will have good collaterals between the left system and the right system, and the left system receives blood from the right system. While the one which does not make a noise, there is no communication, that will lead to the ischemia to the myocardium, myocardial infarction, LV failure, and progressively going for pulmonary artery hypertension, and that will result in coronary perfusion, and gradually the myocardium starts getting oxygen. So the one which makes the noise is less deleterious, while the one which is without noise usually has got a very bad prognosis. Okay, Agna, what else would you like to consider? So we should consider Al-Kappa also as a possibility. Do you think that you would like to consider muscle bridge?
Muscle bridge, yes, we can, sir, actually, but there exist some palpitations,
The palpitation cannot be explained, but and
Yes.
also muscle bridge, usually they are not very large and they are usually asymptomatic. We very often see during coronary angiogram muscle bridge, which does by itself does not give us to significant symptoms. And the coronary arteries underlying the muscle bridge usually does not have any atherosclerosis. Usually atherosclerosis occurs just before or just after the muscle bridge. Underneath the muscle bridge, usually the coronaries are usually healthy and does not have atherosclerosis. Okay, right. These are the possibilities that we are considering. Anybody else who would like to suggest any other possibility? We have considered a few possibilities, out of which I think hypertrophic cardiomyopathy should come quite high in the list.
Yes.
Al-Kappa also is a strong possibility. Mitral prolapse with mitral regurgitation. All those things are important possibilities. Pulmonary artery hypertension, which can press upon the coronary arteries, also can give rise to ischemic symptoms, but they usually will have associated exertional breathlessness. So that symptom is not there, so we cannot keep it quite high in the list. Dilated cardiomyopathy also will keep slightly low in the list.
Yes.
Okay, right. So shall we go to the physical findings?
Yes, sir.
Yes. Okay, right. Yes.
Our examination, patient is comfortable, not dyspneic, respiratory 12 per minute, no PELAS, cyanosis or the clubbing or no edema. On cardiovascular examination, extracardiac examination, pulse rate is 70 per minute.
Extraprecordial.
Extraprecordial. Pulse rate is 75 per minute, regular, high volume pulse, non-collapsing, vessel wall not thickened, all the peripheral pulses are felt, no radial or radiofemoral delay. Blood pressure 130/60 in right upper limb and 150 systolic in left lower limb.
So there is high volume pulse. So
Yes, sir.
from our differential diagnosis, would you like to include few more conditions?
High volume pulse, we get
Anemia.
A physiologic condition first, sir.
Yeah,
Hyperdynamic
very, very.
conditions.
28-year-old IT engineer developing anemia is slightly unlikely. Now you can think of aortic regurgitation. We have thought
Yes,
of
aortic regurgitation.
we thought of the possibility of congenital bicuspid aortic valve, which have both aortic stenosis and aortic regurgitation, and so maybe having a mild to low moderate aortic regurgitation, and that may be the reason the patient is having high volume pulse. Also, the systolic blood pressure in the lower limb is definitely 20 millimeters more than the systolic pressure in the right upper limb. Okay, right, yes. So that aortic regurgitation should be in our mind also. Okay,
Yes, sir.
do you think that this patient can be, with this history, we can think of aorta arthritis or coarctation of aorta?
Coarctation aorta.
Because sir, vessel walls not, sir, and all peripheral pulses felt normally.
Yes. Also, lower limb pressure is more than the upper limb pressure.
Upper limb. So,
coarctation aorta is out.
Yes, sir.
Yes, sir.
Can we consider aorta arthritis?
Sir, yes, it's still possible, sir.
No, I think aortic arthritis is still possible. We should keep our mind open. Only thing is that all peripheral pulses are felt. That is the only point strongly against the aortic arthritis. Because aortic arthritis, we expect some pulses to be, especially upper limb pulses, to be weak or not well felt. But all the vessels, both upper and lower limb, and there is no radio-radial or radiofemoral delay. Sorry, no radio-radial delay. So indicating that that is very low in the list. We push it down to the low in the list. Okay, right. Yes.
JP not elevated. At 30-degree, V wave is seen, which is taller than A wave. Normal Y descent.
What do you mean by that observation?
So V wave is prominent, sir, in this case.
Not grossly prominent at 30 degrees. What's quite, but they just only thing is that V wave is seen and which is taller than the A wave. Normally in the right atrium we expect the A wave
should prominent.
The V wave.
Prominent.
So what are the conditions in which they can get a prominent V wave in the right atrium?
Sir, one is the tricuspid regurgitation.
Very good.
Second is the RSOE to RA.
Very good.
Then ASD with MR.
Very good. Two more conditions.
RV to RA VSG, Gerbord effect.
Gerbord.
RV to RA. Who said RV to RA?
LV to RA.
LV to RA. Very good. LV to RA defect. Yes, very good. One more. One or two conditions. Sometimes any shunt coming to the right atrium other than rupture sinus valva like coronary fistula coming to right atrium. That also can give rise to sometimes not very prominent but slightly elevated V waves. And sometimes both A and V wave can be prominent when there is a tumor in the right atrium. Sometimes right atrial tumors, especially right atrial myxoma, lipoma, they can give rise to, because the whole right atrium is filled with the tumor, and sometimes you can see prominent V as well as A waves. Okay, so these are the various things that we should think whenever we find that the V waves are slightly prominent than the A waves in the right atrium, which is reflected onto the jugular venous pressure. Okay, right. Coming to pre-call examination.
On pre-call examination, inspection palpation, apex bit felt in a 6 left intercostal space on mid-clavicular line.
Okay.
Force,
so
it's a force.
Cardiac enlargement, and that goes with
Forceful.
our impression that it is a walling overload condition. Yes, forceful. Yes.
No sounds or thrill felt at apex. Mild parasternal lift is present. No sound or thrill felt in base of the heart.
Okay. Okay. Percussion.
On percussion, left border abdominis correspond to the apex bit. Second intercostal space on right and left are resonant. Right border of the heart percus 1 centimeter outside the right sternal border.
Now, what does that mean?
So, RA enlargement is there.
Yeah, there is some degree of RA enlargement. So you have to think of conditions where the RA can be enlarged and which can give rise to all these symptoms.
Yes.
Okay, right. Yes.
On auscultation, S1 is normal, best heard at apex. S2 is normal, normal slit. S3 audible at apex. No S4 or no click is there. So S3 is there. On murmurs, continuous murmur, high
What are the
pitch
causes of
blowing.
S3? S3 audible at apex. What are the causes of S3 at the apex?
Sir, in case of ventricular dysfunction, sir, right or left.
LV dysfunction.
In case of increase left ventricular end diastolic volume overload condition.
Okay, high walling overload condition like example.
Yes. In case of mitral regurgitation.
Mitral regurgitation.
So normal physiological also.
Normal physiology.
Yes. In children, up to 10, 12.
No. You can we can hear third heart sound in a healthy young individual up to definitely maybe even up to the age of 30. So even up to the usually it can be easily audible at the age of 20, 25. Rarely up to 30 years. What is the mechanism in young people? How there can be a physiological third heart sound?
Sir, due to young people, due to the hyperdynamic circulation.
What do you want to say? Young people have got hyperdynamic circulation. Why?
No, miss mechanism, sir.
Why did you say that young people are having hyperdynamic circulation? What is the reason that a patient with a young people can have physiological third heart sound? When is this third heart sound usually audible?
Sir, for early
Isovolumetric contraction.
Isovolumetric contraction, you get third heart sound.
Sorry, sir.
No, early arterial systole, sir, means.
Sorry.
During early
rapid filling phase.
Rapid filling phase.
Yes, towards the late part of the rapid filling phase, towards the end of the rapid, large volume of blood is. What may actually generates the third heart sound? Can you explain?
That is a vibration. Due to the vibrations that lead to.
How can there be a vibration?
Large volume of blood flows through the mitral wall that lead to.
No, you have to explain the mechanism.
Sudden deceleration of the incoming blood column.
Due to? See, whenever there is a third heart sound, what this is due to a sudden rise in the LV diastolic pressure. When the LV diastolic pressure suddenly rises, what will happen to mitral valve? Mitral valve floats back. What will happen to the blood flow across the mitral valve? It becomes less. Yes. So the sudden floating back of the mitral valve, along with the deceleration of the blood flow, initiates the vibration of the ventricular myocardium, which gives rise to the third heart sound, and is audible towards the late part of the rapid filling phase. So let us look at a few conditions where there can be third heart sound. In a young individual, how can there be third heart sound? Because of the very efficient sucking effect of the left LV. As soon as the mitral valve opens, the blood from the left atrium is sucked into the left ventricle. When the large volume of blood is sucked into the left ventricle, what happens to the left ventricular diastolic pressure? It suddenly rises. It will not rise to very huge levels, but it may rise from a level of, let us say, 2 or 3 to a level of 7 or 8. It suddenly rises. And that will result in floating back of the mitral valve and also the deceleration of the blood flow, which will result in vibration of the ventricular myocardium and the valve, the ventricular myocardium, and also the blood column. That will result in the third heart sound. The same applies to when there is a large volume of blood flowing across the mitral valve, as can happen in patients with mitral regurgitation, PDA, or in patients with VST. What is the mechanism in patients with LV failure? A similar mechanism. Already there is a large end diastole present in the LV. When the further volume is added, there is a rapid rise in the left ventricular pressure, and that will result in floating back of the mitral valve, and that can give rise to third heart sound. So third heart sound always happens because of the rapid rise of the LV pressure in the during rapid filling phase, which results in floating back of the mitral valve, the deceleration of the blood flow from the left atrium to the left ventricle. That will result in vibration of the ventricular myocardium and the column of blood, resulting in a third heart sound. So as long as your the diastolic function of the heart is very efficient, and there is this very sucking effect of the LV from the left atrium, that can always give rise to a physiological third heart sound. And this can definitely occur up to the age of 25, but even up to the age of 30. So third heart sound in this young engineer can definitely be considered as physiological. But since he has got a cardiac enlargement, I think we should think of the possibility of a volume overload, which can also give rise to increased flow across the mitral valve. So we have to keep our mind open. Okay, right? Go ahead.
On murmurs, continuous murmur, high pitch, blowing best heard over the right sternal border, third fourth intercostal space. Also heard in lower left sternal border. No change with the breathing.
Grade?
Grade 2/6.
Okay. What do you think this murmur could be?
Continuous murmur. VSD murmur, sir.
VSD murmur. Continuous murmur, VSD murmur.
No.
What is the prerequisite for somebody to have a continuous murmur?
Continuous murmur
gradient.
Sir, it is a
start with S1 and it ends beyond the
process
S2.
through the S2, sir. It is heard both in systole and diastole, but crosses over the S2. The duration of systole and diastole does not matter.
Okay. A continuous murmur is a murmur which starts in systole, crosses over the second heart sound to a variable distance into diastole. So it does not mean that it is continuously present, but it should start in somewhere in systole, should cross over the second heart sound and extend variable distance into the diastole. So that is the continuous murmur. What are the prerequisites for a continuous murmur?
There should be gradient persisting in the systole as well as diastole.
No, there should be a communication between a high pressure region and to a low pressure region. One or two, it can be because of a continuous turbulence of flow in an artery or a vein. It can be because of a connection between a high pressure zone and a lower pressure zone. Best example is from aorta to pulmonary artery, as can occur in patients with PDA or AP window, right? Or it can be a communication from an artery to the vein, as can occur any fistula, artery venous fistula, pulmonary artery venous fistula, systemic artery venous fistula, and sometimes, of course, no, it cannot be called as a murmur. The fistulas in other parts of the body, which are known as bruit, can be continuous. So here, what can be the possibility of a continuous murmur on the audible over the right sternal border, third and the fourth intercostal space?
Sir, RSOV to RA.
Very good. That's the one possibility you should strongly consider, RSOV to RA. What is the point against the diagnosis of RSOV to RA?
So the apex peak is down and out.
So what?
And sir, also.
No. I'm not going
Yes,
away from that. No. Don't go away from there. Can the patient with RSOV to the rupture to the right atrium can have an LV enlargement?
Yes, sir. If aortic regurgitation is associated.
No, there is no aortic regurgitation.
Oh.
In a patient with rupture sinusal valsalva to the right atrium, what are the chambers which are volume overloaded, Saroj?
Sir, RSOV to RA, it means sir, volume overloaded chambers will be RA, RV, pulmonary artery.
Very good.
Then, sir, it will come to the pulmonary vein and again.
Yes.
Then, sir, again, sir, can it cause LA and LV also volume overload?
Yes, there is a volume overload of LA and LV. So this is one condition where there can be volume overload of the RA, RV, left atrium, left ventricle. All the chambers can be volume overloaded.
Oh, okay, sir. Means from very distal to the very proximal chamber has come. That's why all chamber can be dilated.
Yes, because the blood flows through the right atrium to the right ventricle, to the pulmonary artery, to the pulmonary vein, to the left atrium, to the left ventricle, and to the aorta. Then only it's shunted.
Okay, sir. Yes, sir. Yes, sir.
So you can get a cardiac enlargement, and the LV can also be enlarged.
So, like in case of PDA, we get LA and LV enlarged.
Yes, in PDA, you get LV enlargement because the shunt is going to the pulmonary artery. So from pulmonary artery to the pulmonary vein, to the left atrium, to the left ventricle, and to the aorta. So the chambers which are enlarged are pulmonary artery, pulmonary vein, left atrium, left ventricle, and aorta. RA and RV are spared.
Yes, sir.
Okay, right. Yes. So what is the point against the diagnosis of ruptured sinus of Valsalva into the right atrium? Any one of you?
It's an acute presentation. Here it's having it.
Yeah, there should be an acute presentation. That's very good, very important point. Usually, ruptured sinus of Valsalva present with an acute symptom, because when the rupture occurs, the patient will have an acute symptom. This patient did not have any acute symptom, so ruptured sinus of Valsalva is very low in the list. Yes. Any other
Jugular
important?
vein.
Alcapa.
S3 should have an RVS3, sir.
Okay, the presence of an RV and LVS3 both can happen. So because of the walling overload, there should be an RVS3, but usually S3 is more frequent in RV or LV. More frequent in LV than RV, but RVS3 we can definitely expect because there is a walling overload of the RV also. Yes, but one very important point. What about thrill?
Superficial.
Yes, sir. Thrill will be present, sir.
Yes, usually rupture sinus valsalva almost always is associated with the thrill, unless you think that the rupture sinus. What is the situation where rupture sinus or valsalva may not have a thrill?
Dissection into IVS.
Very good. Tunneling through the IVS and rupturing into the LV. That may not give rise to a. That may not give rise to a the thrill. Otherwise, the usual ruptures which occur into the right atrium, right ventricle, sometimes into the pulmonary artery, all will be associated with a thrill because that's very superficial. The rupture occurring from the aorta to the right atrium, aorta to the right ventricle, all are superficial and will be almost always associated with the thrill. So the absence of a thrill, you should be careful in making a diagnosis of ruptured sinus of Valsalva. And of course, as somebody has pointed out, usually it will be associated with an acute event. The rupture occurs, there is an acute event. In this gentleman, there is no acute event. So we cannot strongly consider, and also there is no thrill. So ruptured sinus of Valsalva cannot be considered as a strong possibility. Okay, right, yes. What else?
Sir, is it a murmur of Alcapa, sir, with noise? Continuous murmur, not varied with.
I think that we have to consider that a possibility that Alcapa giving rise to the continuous murmur with a noise is a possibility. Yes, no, very good. Yes.
Coronary artery fistula is one more possibility, sir.
Yes, coronary artery fistula to where? To which chamber?
To RA.
To RA. How can it reach the RA? I have forgotten your name. What is your name?
Sir, I'm Shruti, sir.
Shruti. Okay, Shruti, very good. I think you are also, I feel you are well trained. Which institution are you from?
Sir, I'm from MS Ramaya, Bangalore, sir.
Very good. I think your understanding is good. Yeah. So tell me.
Sir, coronary artery fistula opening into RA, sir.
That is right. But usually coronary fistula opening into RA is not very common. Coronary artery fistula, where does it open usually?
Sir, it can open in it can open in all the chambers. Okay. But if it opens into RA and RV, then we will get continuous murmur. If it opens into left ventricle, then usually you'll be getting diastolic murmur.
Okay. But usually the coronary artery fistula usually opens into right ventricle. That is because it is thought that fistulous tracts are actually the remnant of the sinusoids of the right ventricle. Yes. And so the right opening into right ventricle is commonest. And when it reaches the right atrium, usually directly opening into right atrium, yes, it can happen, but very often it drains through the. Shruti.
Sir, I'm not sure, sir.
Can there be any other method by means of which a coronary fistula can reach the right atrium?
Coronary sinus.
Yes, very good. It can the communication can be from the coronary artery to the coronary sinus, and then it can reach the right atrium.
Yes, sir. Yes,
so that is another possibility. So we are thinking of another possibility. I think Alcapa should be strongly considered. and we are thinking whether it could be a coronary fistula to right atrium, directly to right atrium, or through the coronary sinus into the right atrium. Okay, very good. Why are you thinking right atrium? Why can't it be right ventricle? Sudhi,
Sir, sorry, sir, I did not get the question.
why are you thinking that? Why did you say that coronary artery fistula to the right atrium?
Because
And then
right
why can't it be
atrial
the right
enlargement.
ventricle?
Because right atrial enlargement is present, sir.
Very
On
good, excellent. Yes.
percussion, there is.
Yes, very good.
Yes, sir.
On clinical examination, we have found that the right atrium is enlarged because of the percussion node extends 1 centimeter beyond the right sternal border. So, in order to explain the right atrial enlargement, the rupture, the coronary artery fistula into right atrium can explain that finding. Very good, excellent. Yes. Okay, very good. Yes, Egnath, go ahead.
And second, sir, early diastolic blowing high-pitched murmur heard along the left sternal border, better audible sitting up, leaning forward, in breath heard, in expiration, sir.
Okay, what is it?
Sir, it's a AR murmur, sir, aortic regurgitation.
AR murmur. Why are you saying it's AR murmur?
So early diastolic murmur, sir, high pitch.
Oh.
Better heard with sitting and leaning
All
forward.
the features are suggestive of AR murmur. What are the causes of early diastolic murmur?
Sir, aortic regurgitation, sir.
Very good.
Then pulmonary regurgitation.
Which one? Which type of pulmonary regurgitation? High pressure, low pressure? Hypertensive pulmonary regurgitation or normotensive pulmonary regurgitation?
High pressure, sir.
Yes, hypertensive pulmonary regurgitation.
Yes,
you should say that because
and sir, truncal regurgitation.
The low pressure pulmonary regurgitation very often will be heard as a diastolic murmur, and it's a low pitched murmur also because of the pressure gradient is very small. It's a low pitched murmur, and sometimes it can be felt as a diastolic murmur. While the hypertensive pulmonary regurgitation will simulate pulmonary aortic regurgitation. Then how will you differentiate?
By sir,
peripheral signs.
Yeah, very good, excellent. With peripheral signs, very good too.
And sir, inspiration, PR murmur will increase.
Inspiration, PR murmur. Why should it increase? Explain.
No, sir. AR murmur will be better heard during expiration.
Expiration.
Very good.
Isovolumetric hand grip can increase the AR murmur, sir.
Very good, excellent. If you do a hand grip, the AR murmur can increase. PR murmur will not change. Very good. During Saroj, you said during inspiration, PR murmur can increase. Explain.
Sir, no, sir. It will not be there, sir.
Eh?
No.
Why did you change? Then you have to explain why did you change.
Sir, sir, I was wrong, sir.
No, you may be right, but you try to explain it.
Sir, 1 minute.
You think about it. Don't immediately say that no, I may be wrong and all. Just try to see whether you can hemodynamically explain it. During inspiration, what happens?
During inspiration, sir, yes, sir. There is a decrease in the intrathoracic pressure that is carried to the right ventricle. So, sir, RV end diastolic pressure will be decreased. Then, sir, PR murmur.
Why should you say RV end diastolic pressure will be decreased? What will happen to the volume of blood coming to RV?
Sir, it will increase.
It will increase. So, if it increases, what will happen to the RV diastolic pressure?
Oh, sir, yeah, sir, it will increase.
It may increase, and then the gradient between the pulmonary artery and the
RV will decrease. So, sir, PR will decrease.
Yeah, PR murmur actually would not change much with inspiration.
Will not change as much.
Unlike in MR, unlike in TR, where there can be increase in the TR murmur. So PR murmur very often may not change at all. Okay, right? Yes. Or sometimes if the RV is hypertrophied and RV end diastolic pressure significantly rises, then sometimes the PR murmur can actually become slightly less during inspiration. Okay, right? Yes. So you think that it's an early diastolic blowing high pitched murmur is due to pulmonary aortic regurgitation. So the three important causes of early diastolic murmur are aortic regurgitation, most common. Then in congenital heart disease, the truncal regurgitation, and hypertensive pulmonary regurgitation. So as you
Sir,
said,
one more murmur is also early diastolic. That's a flow murmur through the LAD proximal stenosis.
yes.
Dox murmur.
Dox murmur.
Dox murmur also has been described, but in my experience in cardiology, I had never heard a murmur due to a proximal LAD stenosis. But this has been described that there can be an early diastolic murmur because of the proximal LAD stenosis, because the coronary flow during diastole can cause an early diastolic murmur. And this is described by a doctor known as Dox. And the name goes with his name. Dox murmur. Okay, right? Yes. Next murmur.
Sir, third murmur is a mid-systolic ejection murmur, harsh medium pitch, early picking, well audible in aortic area and pulmonary artery, no conduction, grade 3/6. It's aortic stenosis murmurs.
Maybe aortic stenosis or maybe very mild aortic stenosis, because it is an early peaking murmur. So it could
Yes,
be
sir.
even a
Flow murmur
possibility.
also.
Flow should also be considered, but it has
Flow murmur through the pulmonary.
yes, it can
Very
be
early. That is early, sir. Flow murmur occur early. Early systolic murmur.
yes, early systolic murmur. Okay, no, not early systolic murmur, mid systolic murmur.
Mid systolic and early peaking is also there.
Yes, sir. Mid systolic peaking, early peaking murmur. It is well audible both aortic area and pulmonary area. Can these patients have a pulmonary ejection murmur, aortic ejection murmur? Due to a
Yes, sir. Pulmonary ejection murmur can be present, sir.
yes. How can there be a pulmonary ejection murmur?
So because of the increased flow through the right side of the heart.
Very good. When there is a communication coming to the right atrium, which we were thinking as a possibility, then there can be flow to the right ventricle, and increased stroke volume of the right ventricle can give rise to an ejection systolic murmur, which is an early peaking mid systolic murmur. Okay, right. And similarly, the volume can come more onto the right, to the left ventricle also, and that also can give rise to an ejection systolic murmur. On top of that, we have got some evidence to conclude that the patient is having some degree of aortic regurgitation also. So both the murmurs we must consider as flow murmurs, because they are mid-systolic but early peaking. Okay, right? Yes. Other systems, normal. Okay,
Normal.
right. Yes. Okay. So after a clinical examination, what are your possibilities?
Sir, actually, this AR is accident. Yeah, it could be a bicuspid aortic also. AR.
Okay.
And
you may be having a congenital defect which is giving rise to maybe tricuspid valve also, because aortic regurgitation as a congenital defect is more frequent when the cusp number increases, 3 cusps, 4 cusps. But when the cusp number decreases, the aortic stenosis is more likely lesion. Of course, in bicuspid aortic valve, you can get sometimes aortic regurgitation also. So congenital aortic valve abnormality giving rise to some degree of aortic regurgitation. Very good. Yes.
Yes. So that lead to the exertional palpitation. That could be the one possibility.
Very good.
Sir, in case of continuous murmur, it could be a alcapa, and that can lead to the exertional chest pain, sir.
Then how will you explain the right atrial enlargement?
Yes, sir.
Right atrium is the right sternal border. The right border of the heart is focused 1 centimeter beyond the right sternal border. How will you explain that?
Yes, sir. Okay, sir. The coronary
RSOV to RA is coming.
Sir, RS multicuspid means quadricuspid, or these valves are more common to cause the RSOV. So maybe quadricuspid means multiple congenital multiple aortic valves with that can cause aortic regurgitation also, and they are more prone for RSOV. So that
only problem is the
RSOV to RA.
History is not suggestive, because the patient usually rupture senescence cell will have an acute event. Usually that's a pattern.
Yes,
that is not there. So that is a slight oddity, that patient is having a aortic rupture senescence cell with no acute symptom. So do you think that this could be a communication between the coronary artery and the right atrium?
Yes, sir. But then
Yes, sir.
how aortic regurgitation we can explain, sir?
Aortic regurgitation, we cannot explain aortic regurgitation. For aortic regurgitation, you have to bring in another congenital anomaly which can give rise to aortic regurgitation. Okay, so these are the possibilities that we can think. So let's go to discussion on continuous murmurs. Yeah, you must know about continuous murmur. Continuous murmur definition. Agnaz, you can read.
Yes, sir. A continuous murmur definition: any murmur which starts in systole and spills over second heart sound into the diastole is a continuous murmur. Most continuous murmurs peak toward the second heart sound and end in mid diastole. Occasionally, continuous murmur can extend into the end diastole and end in a first heart sound. Prerequisites for the production of the continuous murmur. First, the connection between the high pressure zone, that is the systemic artery, and low pressure zone, that is the pulmonary artery of the systemic vein. Second is continuous turbulence in a vessel due to the high flow of the significant stenosis. The clinical condition causing the continuous murmur. First is the aorta to low pressure zone communicating. Examples are
communication, low pressure zone communication. Aorta
yes,
to a low pressure zone communication. Yes.
Yes, sir.
Example.
Patent ductus arteriosus, AP window, RSOE, AP collaterals, man-made shunts. Then second is a coronary artery
All these
communication.
are causes for a continuous murmur due to a connection between aorta and the low pressure zone. Okay, right, yes.
Then coronary artery communications. Examples: coronary artery camber fistula, and second is the Alcapa. Then aortovenous communications. Examples are
arteriovenous communication.
arteriovenous communications. Examples are pulmonary arteriovenous fistula, intrathoracic arteriovenous fistula, peripheral or cerebral arteriovenous fistula. Bruit is there.
They cannot call it as a murmur. They are actually, you have to mention it as a bruit. Murmur is described only when the sound noise is produced in the heart or in the vicinity of the heart. Away from the heart, when you hear a noise, you call it as a bruit, not as a murmur. Okay, right? Yes.
Artery to artery collateral in case of coarctation of aorta. Turbulence flow through the veins in case of venous hum. Turbulence flow through the artery in case of mammillary shuffle. Flow through a critically stenosed artery in case of coarctation of aorta and aorta arteritis. Flow through a stenosed vein in case of turbulent flow in stenosed TAPVC in supracardiac. Miscellaneous causes are left to right shunt, more left through the open PFO in case of mitral stenosis.
It's very rare. Sometimes in a patient with mitral stenosis, nowadays we don't see that. But I have heard 4 or 5 cases of mitral stenosis coming with a continuous murmur. And this is due to opening up of the patent foramen vein because of the dilated left atrium and the flow of blood from the left atrium to the right atrium. Okay.
Two lesions.
We don't see that. Okay. Yeah.
Two lesions mimicking continuous murmurs are VSD with aortic regurgitation, mitral regurgitation with aortic regurgitation, and hypertension tricuspid regurgitation plus with pulmonary regurgitation.
Okay. Out of which this VSD with AR is the one which actually can mimic a continuous murmur closely and sometimes confuses. Okay, right?
How to analyze to reach the diagnosis? Associated with severe cyanosis, pulmonary AV fistula, continuous murmur can be heard anywhere in a lung field. However, most frequently audible in intrascapular area or auscultation over the precordium. Heart sound will be normal and S2 will be normally split.
Okay, what is the intervention that or procedure that you can do to diagnose pulmonary arteriovenous fistula?
As a contrast equation.
No, clinical examination.
Then in case of
Orthodeoxia platelet syndrome.
No.
Sir, bruit over the scalp in a small child.
Beg your pardon?
Sir, is this growing over the scalp in small child?
All right, no. You are thinking that this in a child when there is cyanosis and you are hearing a continuous murmur in that region, you are thinking of pulmonary arterial fistula. What will happen? Have you heard of Mulder's procedure?
Sir, leg raising test, sir.
Beg your pardon?
Leg raising test,
Leg
which
raising test.
increases flow on the right side.
All right, but it takes some time because it has to go to the right atrium, right ventricle, to go to pulmonary artery. Then only it can increase. So it takes a few beats. Have you heard of Mulder's procedure?
Yes, sir. Opposite of Valsalva.
Forced
Opposite of
inspiration against closed
Valsalva.
door.
Yes. So when you do Mulder's procedure, what will happen to murmur of pulmonary artery venous fistula? What happens to the endarothoracic pressure in a patient with when you do the Mulder's procedure? What happens to endarothoracic pressure when you do Valsalva?
It will increases.
It increases. And Shruti, you said that when you do Mulder's procedure, you are having the opposite effect of Valsalva procedure. Valsalva. So what should happen to the endothoracic pressure?
It should decrease, sir.
It should decrease. Now, Valsalva is a forced expression over a closed glottis.
Yes,
And Mulder's procedure is forced inspiration over a closed
glottis.
can result in low endothoracic pressure. And then what will happen to the pulmonary veins?
Pulmonary veins.
It will flow to left side increases.
Yes, pulmonary veins can actually dilate because of the low endothoracic pressure, and the flow through the artery venous fistula can actually increase. And with Mulder's procedure, we can see the murmur can increase. Actually, when you do a screening procedure in these patients, if you are seeing a rounded shadow, which you suspect that it could be an pulmonary artery venous fistula, you can make the patient do a Mulder's procedure. And when you do Mulder's procedure, the fistulous tract becomes bigger. And when you do a Valsalva procedure, what will happen to the fistulous tract?
It will become narrow.
Become less. So by doing a Mulder's and Valsalva procedure, with Mulder's procedure, the pulmonary artery venous fistula can become bigger, the murmur can become louder. And with the Valsalva procedure, the pulmonary artery venous fistula can get compressed, and the murmur can actually come down. So you can do these two interventions, especially in a suspected case of pulmonary artery venous fistula, to make the correct diagnosis. Correct. Go ahead.
Epicollatus in low flow congenital heart disease. Continuous murmur most frequently audible in infraclavicular area, can be detected in infrascapular area. On auscultation, S2 is single. Associated with the
patients with low flow cyanotic congenital heart disease like pulmonary atresia, you can always have epicollatus, and the continuous murmur can be audible. Very often it can be audible anywhere in the infrascapular area, or it can be audible, not in the suprascapular, is very rare. It can be audible in the infraclavicular and suprascapular area, but it can be heard anywhere. Sometimes it can be in the scapular area, you can hear. Lower scapular area, but infrascapular area, it is not usual. So it can be audible anywhere, but most frequently it is audible in the infraclavicular area. That is the very area, and can be detected in the interscapular area also. You should very carefully look for continuous murmur, especially in a patient with cyanosis where no murmur is audible. And the P2 and the second heart sound is not very loud, where a possibility of pulmonary atresia should be thought of, and look for a continuous murmur carefully. Okay, right? Yes.
Associated with superficial trees in case of rupture of sinus of Valsalva. Continuous murmur in third and fourth left and right intercostal space close to sternum. RSOE with thrill. Coronary artery fistula without thrill.
Yes, whenever you are hearing a continuous murmur in the third and the fourth, left or the right intercostal space, if it is associated with thrill, go for RSOV. No thrill, always diagnose coronary artery fistula. It can be to right atrium, to right or to right ventricle, but always think of the possibility of coronary venous fistula, coronary artery fistula. Whenever you are hearing a continuous murmur in the third or the fourth left or the right intercostal space close to sternum and no thrill. If there is a thrill, go for ruptured sinus of Valsalva. Right, okay.
Continuous murmur in second and third and or fourth left intercostal space close to sternum, no thrill, alcapa with right coronary artery to left coronary artery collaterals.
Yes. Sometimes this continuous murmur may be very well audible in the second left intercostal space where the left coronary artery opens into the pulmonary artery. And sometimes you can hear the continuous murmur very, very loud in the second. It can be heard sometimes in the second, third, and fourth left intercostal space close to sternum. Not usually associated with the thrill. So alcapa also is a very strong possibility that you have to consider when you are hearing a murmur in the second and third intercostal space close to sternum, mostly on the left side, not on the right side. Okay, right? Yes. So you should be very clear how to look at the continuous murmur, what are the mechanisms of continuous murmur, and also how will you analyze a continuous murmur to come to a proper diagnosis. Okay, go ahead further.
How to analyze to reach diagnosis? Then, associated with mild cyanosis, look for evidence of previous surgery. Man medicine, continuous murmur best audible in right or left infraclavicular area. In case of BT Gore-Tex or Watterson stent, and left interscapular area in case of pot stent.
Yes, the blenoctosic, Gore-Tex, and Watterson stent all are audible in the front part, while the pot stent is audible in the left interscapular area posteriorly. Yes, right.
Associated with mild cyanosis, continuous murmur in second right intercostal space in case of total anomalous pulmonary venous connection.
Yes, especially supracardiac variety. Yes.
Yes.
How can there be continuous murmur in total anomalous pulmonary venous connection? Eknath?
Sir, in supracardiac types, there is single communication to the RA.
Eh? What did you say?
If TAPVC is of supracardiac type, then sir, we get it.
Yes, Saroj, what did you say?
Sir, in cases of TAPVC of supracardiac type.
Yes, yes. How can there be continuous murmur?
Hemodynamic wise.
Sir, there is a stenosis, sir. Obstructed.
Yeah. Very often these patients, this region where the vertical vein or the common pulmonary vein opens into the superior vena cava, sometimes there can be some degree of stenosis. And when there is a large turbulent volume of blood flowing through this stenosed segment, can sometimes give rise to a continuous murmur. So sometimes in patients with supracardiac variety of TAPVC, sometimes there can be continuous murmur. And when there is a continuous murmur, very often this is best audible in the second right intercostal space. That is the region where the anomalous common pulmonary vein can join the superior vena cava. Okay, right? Yes, go ahead. Okay. Usually it is associated with mild cyanosis, or there may not be any cyanosis at all even. Sometimes you may have to exert the child to bring out the cyanosis. Because very often these patients, at what level of oxygen saturation you will be able to detect cyanosis, Eknath?
Up to 85% of saturation.
Yeah, around 85 or less than 85%. When the pulmonary oxygen saturation is around 90%, you may not be able to detect the cyanosis at all, or you may have to exert the child, and sometimes you may be able to detect it. So very often patients with total anomalous pulmonary venous connection can have oxygen saturation around 90% and may have only very mild cyanosis, difficult to detect sometimes. Okay, right. Yes, go ahead.
In case of no cyanosis, continuous murmur best audible in first or second left intercostal space close to the sternum. In case of PDA, venous hum, continuous secondary is continuous murmur best audible in second and third left intercostal space close to the sternum AP window.
Okay.
Then in case of no cyanosis condition, another condition, coarctation aorta, Continuous murmur of collateral best audible in axillary and infra-axillary areas. Continuous murmur due to the flow through the stenos segments best heard over the dorsal spine.
So in a patient with coarctation of aorta, continuous murmur can be due to two mechanisms. One, continuous murmur because of the continuous flow through the collaterals, which is audible in the axillary and infra-axillary area, or continuous murmur due to flow through the stenos segment. In a very tight coarctation of aorta, sometimes the gradient across the coarctation may be significant during systole as well as during diastole, so that you can get a continuous murmur. Okay, so that can give you the it's best audible over the dorsal spine. Okay, right, go ahead.
Continuous murmur of aorta ulteritis. Site of continuous murmur depends on the site of stenosis.
Yes, it depends upon the site of stenosis. The stenos segment is the one which gives rise to continuous murmur. So in aorta arteritis, various regions can be involved, giving rise to continuous murmur at different sites. Okay, right, yes.
Continuous murmur in the third right intercostal space close to sternum in case of mitral stenosis is the flow through the open PFO.
Yes, patent foramina. Okay, right, yes.
Then two lesions mimicking continuous murmur are careful auscultation. Most difficult to differentiate is the VSD from AR. VSD with AR.
VSD with AR. Okay.
Yeah.
Okay, right. So these are the various causes of continuous murmur. And when you face a continuous murmur, how to analyze the continuous murmur to come to a correct diagnosis. Now, this patient had aortic early diastolic murmur. So how will you differentiate aortic regurgitation and pulmonary regurgitation? Yes.
Diastolic murmur changes with posture and the maneuvers. Aortic regurgitation better audible in sitting up, leaning forward, and breath held in expiration. Increases with squatting and hand grip.
Yeah, that's very important. If you can always do a hand grip, and aortic regurgitation murmur can actually increase. Why? How can hand grip increase the aortic regurgitation murmur? Ignore.
Sir, hand grip increases after load, sir.
Yes.
And increasing after load increases the diastolic flow.
Yes. The hand grip increases the pulmonary, the systemic vascular resistance increases, and that can result in increase in the diastolic pressure, and the pulmonary aortic regurgitation can increase. Okay, right? Yes.
Decreases on standing and the strain phase of Valsalva maneuver.
Okay.
In the release phase of Valsalva, the murmur becomes louder after 7 to 8 beats.
What is the mechanism?
Sir, increased flow.
What is the mechanism that in release phase? So you have to think what happens in release phase, and how is it that the murmur becomes louder after about 7 to 8 beats?
There will be increase in the preloading release phase, sir.
Sir, heart rate will decrease and the diastolic period will increase.
Heart rate will decrease and diastolic phase will increase. Why should the heart rate decrease and why should the diastolic phase increase? Why should the heart rate decrease?
Sir, in release phase, there will be increase in the venous return.
Yes, that's the most important point. There can be a slight change in the heart rate, but most important point is that there is a significant increase in the venous return. Why there is an increase in the venous return?
Decrease intrathoracic pressure.
Yes, there is a sudden decrease in the intrathoracic pressure, and the whole volume of venous blood, which is not flowing into the thorax because of the high intrathoracic pressure, suddenly flows into the right side of the heart. And the time taken for the increased volume of blood to reach the left side of the heart is around 7 to 8 beats. If the murmur increases within 2 to 3 beats, it's the right side of the murmur. And if the murmur increases after about around 7 to 8 beats, it's most likely a left sided murmur. The release phase of Valsalva gives you the clue to the diagnosis of whether it's a right sided murmur or a left sided murmur, depending upon the timing at which the murmur changes. The murmur which increases within 2 to 3 beats is the right sided murmur, and the murmur which increases after about 7 to 8 beats is most likely a left sided murmur. Okay, right? Yes.
In case of
Hypertensive pulmonary regurgitation. Hypertensive pulmonary regurgitation. Yes.
hypertension pulmonary regurgitation, no change with hand grip, no or minimal change with squatting, increase on lifting the legs, decreases during the Valsalva strain phase. On Valsalva release phase, murmur increases with 2 to 3 beats.
Yes. So these are the points by which you can, and for both the conditions, if you are very careful auscultator and if you can really make out the pulmonary aortic regurgitation murmur starts with A2 and the pulmonary regurgitation murmur starts with P2. So that also can be added as a differentiating point. If you are a astute auscultator, the murmur which starts with A2 is a aortic regurgitation murmur and the murmur starts with P2 is a pulmonary regurgitation murmur.
Sir, once more, please explain how aortic regurgitation murmur increases in the release phase of Valsalva.
Okay.
Sir, I understood that during the release phase of Valsalva, so the venous return is coming more.
Yes.
Yes, sir.
There is a sudden release of the increased intrathoracic pressure, resulting in venous return to the right side of the heart increases.
Increases. Yes. So preload coming to the left side of the heart also increases.
Yes.
So, sir,
no. The preload coming to the left side of the heart, why does it increase?
Oh, okay. Oh, no, sir. Yes.
What happens to the flow to the left side of the heart?
Sir, it will decrease rather.
Decrease. It will decrease. Why?
Sir, because, sir, more blood in the pulmonary bed.
Yes, the pulmonary bed actually expands and it can contain more volume of blood, and there is a reduction in the
return to the left side of the heart.
And actually, the left side of the murmurs can actually decrease for 1 or 2 beats before it increases after about 6 to 7 beats.
So, sir, return to the left side of the heart is decreased. That's why, sir, the aortic regurgitation will increase.
Yeah, because of the extra volume of blood which is pumped out from the right ventricle will reach the left side of the heart after about 7 to 8 beats, and then the volume of blood coming to the left atrium, left ventricle increases, and that will result in a more prominent aortic regurgitation.
Okay, sir. Okay, sir. Thank you, sir.
Right. Okay, now we'll go to investigations. What do you expect in a patient with what is the electrocardiographic abnormality that you can expect when there is a large volume of blood coming to the right atrium, either due to a of course in a patient with AV coronary artery fistula, you can have a large volume, but in rupture signs of Valsalva, volume is definitely much bigger. And so, what will be the electrocardiographic abnormality? We have already discussed that they can have the right
ventricular hypertrophy,
volume overload of the right atrium, volume overload of the
right ventricular dilatation,
right ventricle, left atrium, left ventricle. So, what will be the electrocardiographic abnormality?
All chambers will be enlarged.
Yes, they can have they can have biatrial enlargement. Yes, when there is a volume overload of the right ventricle, how do you diagnose it?
Sir, prominent R in V1.
A little more, slightly more descriptive. Prominent R is mostly associated with the
yes, sir. Yes, sir. Pressure overload. Sir, yes, sir.
Q wave in right precordial lead along with
that is also pressure overload.
The Q wave, small Q wave,
small Q wave with upright T waves in right precordial lead, sir.
That can happen when there is associated RA enlargement. It is not a feature of RV volume overload.
So right axis will be there.
Yes, there can be some degree of what very often when they got both right and the left ventricle are both are involved.
And sir, QRS duration will be little increased.
Yeah, RSR dash pattern. That's what you should say. There can have an RSR dash pattern, big one, because of the volume overload of the right ventricle, where the infundibulum also is dilated, you can get an RSR dash pattern in V1. So whenever you find an RSR dash pattern in V1 and evidence of volume overload, the left ventricular hypertrophy, always think of the possibility that the volume of blood is coming both to the right side and left side is increased, and rupture signs of Valsalva is a possibility. So RSR dash with LV volume overload, rupture signs of Valsalva is a possibility, or any condition where there is an increased volume of blood coming to the right side of the chamber, right heart, right atrium, or the right ventricle, and which subsequently has come to the left side, and both the right and the right side, both the right and as well as the left side, both are wholly overloaded. Okay, right. Yes. So let's look at the electrocardiogram. Egna?
Yes, sir.
What do you find?
Sir, lead 2 is ectophagic, sir. So yeah.
Minus 30
So
degree
axis is minus 30 degree.
X deviation.
Yes, sir. Then, sir, there is
any volume overload of the atria?
atrial volume overload. Sir, actually, just one.
Sir, a little RA is prominent. V1 prominent.
V1 is there is. Sir, SV is prominent then RV, sir. So we can say it's a type 3 RVH.
Yes, there is evidence which will be volume overload. As evidenced by what is height of the R wave in V5?
V5 actually said that
1, 2, 3, 4, 5, 6, almost 30. 32
yes.
Sir,
significant.
volume overload for LV is there, sir.
Yes, there is a volume overload of the LV is definitely there because
Yes, sir.
there is a very prominent R wave.
Sir, Q wave also present.
Yes, there is a Q spot. And also there
are upright T waves.
Yes, upright T wave, and width of the QRS complex is not increased.
Narrow.
So there is evidence of volume overload of the LVH volume overload.
Yes.
What are the features of LVH pressure overload?
So in case of pressure overload, you get that is ST depression with the T wave inversion.
Yes, there can be ST
V5 in lateral, it's V5, V6 or one.
ST downsloping ST with T wave inversion.
And sir, intrinsic deflection also. Sir.
Intrinsic deflection also.
What? You have to describe it. What do you mean by intrinsic deflection?
Sir, the time taken from Nadi to peak of the R wave, it will be a little more. Sir, QRS duration will be more.
That is
0.09, sir.
What is it known as? From the beginning of the QRS complex to top of the R wave.
Ventricular excitation time.
Yes, not acceleration.
Activation.
Yes.
Activation time.
What will be the duration of the ventricular activation time in pressure overload?
So more than 0.08. No, 0.04.
Yeah, it's definitely more
than one segment, more than one. Yes.
Usually it can be more than equal to or more than 0.04. Normally, very often it is 0.05. Usually more than 0.04. Ventricular activation time will be prolonged, and that will be equal to or more than 0.05. When it is 0.05, you are sure about it. So the ventricular activation time can be prolonged in a patient with pressure overload, which can be 0.05 or more. Okay, right? Yes, and there can be associated STT changes. The height of the R wave, height of the R wave may not be as prominent as in a volume overload LVH. Okay, right? Yes. Coming to exit chest.
It's exit chest PA view.
So in the ECG, RV is also, sir, prominent.
RV is not.
Sir, V1 prominent R is same, sir.
Well, I think LV is much more dominant. I agree with you that the height of the R wave is more than 7. That may make you suspect.
And sir, in 28-year-old, sir, so please.
Yes, I think the height of the R wave in V1 initially it is around 7. That you make you suspect that you can always definitely. One of the criteria for right ventricular hypertrophy is that the height of the R wave in the initial R wave in V1 is equal to or more than 7. And in presence of significant left ventricular hypertrophy, some of the right ventricular hypertrophy, even if it is there, can get neutralized because of the dominant left ventricular hypertrophy pattern. So I agree with you, with Saroj, that you can discuss a possibility of associated right ventricular hypertrophy. Yes, okay, very good. Yes, good point. X-ray chest.
X-ray chest behavior. With normal exposure here.
Yes.
So with RV type of apex is there, sir.
I will not comment. I will just be
Cardiomegaly, sir.
non-committal.
Cardiomegaly.
Normal. There is a cardiomegaly and the apex is normal, neither suggestive of RV or LV. Okay, Rajesh.
Then
what about the
pulmonary artery? It's looking normal actually. Right pulmonary artery.
Not right pulmonary artery. The pulmonary artery segment.
See, no. The absence of pulmonary.
Sir, plethora is present, sir.
Pulmonary artery segment is definitely
little prominent, sir.
Little prominent. Definitely prominent.
The biatrial enlargement also.
Pulmonary base, it is not concave, sir. It looks full.
Yes, sir. Straight, sir.
Usually you will have a slightly concave pulmonary artery segment is slightly concave. Here it is convex and is full, indicating that pulmonary artery segment is prominent. Very good. Very good. Yes. Left atrial appendage.
Straightening of border is there, so enlargement is also there.
Yeah, so the looking at the area of the left atrial appendage, it also appears full, and so you have to suspect that the left atrial appendage also is really enlarged. Yes.
The double contour also there, sir.
Yes.
All right, I think I agree with you. There is a double shadow.
Yes, a double contour is there, sir.
Sir, and RA enlarged, sir.
Yeah, yes.
1, 2, 3. Okay, there is an RA enlargement. So biatrial enlargement, there is a slightly prominent pulmonary artery segment, left atrial appendage is prominent, cardiac enlargement. Is there any evidence of
multiple end-on views are seen, sir?
Yes, there are multiple end-on vessels are seen. You can see
the little pulmonary venous prominence also there.
Let me see.
PVH features.
Upper lobe veins are prominent.
Yes, upper lobe.
Yes. Upper lobe veins are full and slightly enlarged. You can see end-on vessels 1, 2, 3, 4, 5, 6. Multiple end-on vessels indicating that there is increased pulmonary blood flow. And also, as somebody has pointed out, the upper lobe vessels are full. I can't use the word prominent because see, when a shunt lesion, what happens to upper lobe vessels?
There should be cut off.
No, then when they develop pulmonary arterial hypertension, there can be a peripheral cutoff. But in a patient with shunt lesion, for example, in a patient with AST, what will happen to upper lobe vessels?
Flow will increase, sir.
Yes,
it should be more prominent
because of the large pulmonary blood flow. But the most differentiating point is that you have to compare with the lower lobe vessels. So in a patient with ASD, lower lobe vessels also will become much grossly enlarged, and still the lower lobe vessels will remain much larger than the upper lobe vessels. Upper lobe vessels can become prominent in a shunt lesion, but compared to lower lobe, it can never become more prominent unless the patient is associated with left ventricular or left atrial pressure enlargement resulting in pulmonary venous congestion. So in a patient with a shunt lesion, you can get really dilated upper lobe vessels, but it will not become more dilated than the lower lobe vessels. Okay, right? Yes. So does this X-ray help you in making any diagnosis?
Bilateral arterial enlargement is there, sir.
Very good.
Then,
there is evidence of shunt lesion. End-on vessels are seen. Pulmonary artery segment is prominent. Cardiomegaly is there. So there is a volume overload, and also there is some shunt is there. So a possibility of a communication from the left side coming to the right side of the heart is there. So either a ruptured sinus of valsalva or some shunt is there. So we'll have to look at the further investigations to come to a diagnosis. Yes, let's look at the next investigation. Okay.
So on left side, sir, in upper panel, this is parietal long axis view. In that, we are seeing the coronary sinus is dilated, sir.
Okay, very good. What are the causes of coronary sinus dilatation?
Rupture of coronary.
LSVC.
What are the causes of
LSVC2.
LSVC2.
yes, LSVC to the coronary sinus. Very good.
And sir, unroofed coronary sinus.
What did you say?
Sir, unroofed coronary sinus.
Unroofed coronary sinus, why should it be? It may be slightly dilated. What happens in unroofed coronary sinus?
Sir, there will be cyanosis.
Why should there be cyanosis?
No, sir.
In unroofed coronary sinus, what happens? Anybody?
Sir, like ASD, sir, it will behave like ASD.
Because when there is unroofing of the coronary sinus, the right atrial pressure is more than the
LA pressure, sir.
left atrial pressure is more than the right atrial pressure.
Yes, sir.
And because of that, the blood will flow from the
LA to RA.
LA to RA
through coronary sinus.
Coronary sinus. So they may behave like something like an atrial septal defect. Okay, right? Yes. Here, so unroofed coronary sinus, then the left IV SVC draining into the coronary sinus. Third mechanism, third.
Yes, sir.
Very hypertension. TAPVC.
Yes, very good. Sometimes there can be pulmonary, partial pulmonary TAPVC into the coronary sinus. Very good. Excellent point. Yes.
Sir, there is a stenosis near the
failure,
near the opening
failure.
of coronary sinus to RS, sir.
All right. If there is a stenosis of the coronary sinus to RA, it can give rise to coronary sinus enlargement. Yes, very good. Why did you say LV failure?
Sir, from backflow.
Oh, you are right. But is it LV failure or some other failure?
Sir, so that effect is there. Edema.
RV failure. RV failure can give rise to elevation of the right atrial pressure, and consequently the coronary sinus can be
dilated.
Yes. Okay. Yes. So there are multiple reasons for coronary sinus dilatation. And you are here seeing one color flow inside the coronary sinus, almost continuous. So do you think that this could be an arterial flow coming to the coronary sinus?
So since it is continuous, so I would like to think it is coming from arterial system, high pressure to low pressure.
Very good. So
coronary artery fistula opening into coronary sinus is one possibility, sir.
Very good. Excellent. Yes, I think this instance there is a continuous flow. You have to consider that it is a high pressure communication coming to the coronary sinus. So it could be a coronary cameral fistula opening into the coronary sinus. Okay. Right. We'll go to the next group of. Okay. Yes.
Sorry.
What about the LV? Is it dilated? Is there a
LV is right upper or left upper panel, sir. LV is looking dilated, sir.
Very good.
Then next severe AR is there, sir.
You cannot use the word severe AR, mild to moderate.
Mild to moderate AR. Okay.
Yes. Is there an MR?
Yes. MR.
Sir, AML prolapse is there, sir. Anterior mitral leaflet prolapse is present. It is elongated.
How can we diagnose? Yeah. Let me see.
Lower panel, I didn't.
On the left side, and even the previous view.
In which view do you diagnose prolapse?
AML is elongated and it is
Plaques view, sir. Plaques
Plaques
and
view. You have to
case of-
it's a par-
view. And what is the criteria to diagnose mitral prolapse?
more than 2 mm during the systole.
On the annular plane.
Yeah, the one cusp or both cusps should project beyond the mitral annular plane into the left atrium. Then only you can call it as a mitral prolapse. When you call it a flail mitral valve,
And the tip extends beyond to the LA.
So during systole and diastole, both
both systole and diastole.
no. A flail means, sir.
The tip of the mitral valve leaflet reaches the LA.
When proper coaptation is not there and one leaflet
Yes, sir.
collapse into LA.
That's not the exact definition. You are almost right. The one mitral leaflet, the tip of the mitral leaflet should point towards left. Prolapse is there, but the tip should point towards the left atrium. Then only you will call it as a flail mitral valve. If it is into the left atrium, that is not enough. That it should be into the left atrium, and tip of the prolapsing leaflet should point towards the left atrium. Then you call it as a flail leaflet.
yes, sir.
Here, well, I agree with you that there's some bending moment, but the coaptation point is not crossing over the mitral annulus into the left atrium. So I will have great difficulty in diagnosing mitral prolapse.
Yes, sir.
Okay, this we have already seen. What is here? The third one?
Third one, sir. There is a turbulence is there, sir. One and that opening into the LA.
Okay. Opening into LA.
That is
Coronary.
coronary.
The coronary sinus is prominent.
Coronary
Yes,
sinus.
It is there's a continuous turbulence in the coronary sinus. Okay, right, yes. So this could be a coronary artery venous fistula. Okay, so. Why was this contrast done? And from where was it done?
From the left side, left arm.
Oh, yes, it is done from the left arm. Why it is done from the left arm?
So for LSVC.
Yes, you want to know. So is it LSVC or not?
No, sir.
Why?
Sir, because in case of LSVC, first it will come to the coronary sinus,
Okay,
then to the RA.
Very good. So in here, the contrast is reaching the RA and then it actually gets reflexed into the
Coronary sinus.
So it is not a left superior vena cava draining into the coronary sinus. Is it clear to all of you? When you do a contrast echo, if it is a left SVC draining into the coronary sinus, the contrast should reach the coronary sinus first, and then it will drain into the right atrium. You have to inject the contrast into the left upper limb, because the contrast should go to the left superior subclavian vein into the innominate vein then it should drain into the left into the coronary sinus, and it then to the right atrium. Because of that, the contrast will reach the coronary sinus first and will reach the right atrium subsequently. So here the contrast is reaching the right atrium first and regurgitates into the coronary sinus, indicating that definitely it is not a superior vena cava, left superior vena cava draining into the right atrium. Sorry, draining into the coronary sinus. Okay, what does this indicate?
There is flow during both systole and
Yes, there is a continuous flow during systole and diastole, and you can clearly see that actually it is very difficult to get the flow here because the interrogation is not parallel to the flow. It's almost at right angles to the flow. In spite of that, there is a significant flow detected, indicating that there is a continuous flow into the coronary sinus. So, what is the diagnosis? Okay, few points. Coronary fistula. Yes.
Yes, sir.
Read.
Coronary artery fistula. It's a communication between the coronary artery and the cardiac chamber, coronary sinus, or the rarely pulmonary artery. The artery involved are RCA in 55%, left coronary artery 35%, and the rest both are involved. The commonest site of communication is to the right ventricle. This is due to the persistence of embryonic intertrabecular space and the sinusoids.
So RV has got plenty of intertrabecular spaces and sinusoids, and that will result in the persistence of these spaces will result in the coronary artery fistula to the right ventricle. Yes, very good. Yes.
The shunt through the fistula increases over a period of time.
Yes, initially it may not be symptomatic, and over a period of time the shunt can increase, and that can sometimes give rise to coronary steal effect, and that is how they become symptomatic later in life.
Coronary artery fistula complications, infective endocarditis, thrombus of the fistula can cause myocardial infarction. It's a rare complication. Coronary steal phenomenon if the shunt is large. Large shunt can rarely causes pulmonary artery hypertension or congestive heart failure in the case of rare complication.
Okay, right. Yes.
Coronary artery fistula diagnosis and treatment. Clinically, continuous murmur in the parasternal region, left or right, without a thrill. ECG mostly normal unless associated with the large shunt. Echocardiogram can detect the fistula. Coronary angiogram required to locate the fistulous tract. Treatment, coiling embolization, sometimes surgical treatment.
Coil embolization.
Then sometimes surgical treatment is required if the fistulous tract is large.
Okay, yes. I think that's all about. So the diagnosis actually was a coronary fistula into the coronary sinus, and patient actually we recommended that you should undergo a coronary angiogram and the coil embolization of the fistulous tract. But the patient was not. He said he's not very much symptomatic, and since it was told to him that it's not a life-threatening problem, he said he does not want any further investigations. So he's coming for follow-up. He's still asymptomatic. He's leading an active life. So any doubts, any questions about the coronary artery fistula and also continuous murmur?
Sir, how to correlate this aortic regurgitation with this one?
You cannot correlate. I don't remember whether he had a bicuspid aortic valve. Since he had a congenital defect here, probably he might have had some congenital aortic valve defect, and that must be the reason for his aortic regurgitation. You cannot have, both cannot be correlated.
Yes, sir.
Maybe independent, and maybe I don't remember whether he had a bicuspid aortic valve. Otherwise, I would have said that. He might have had some coronary. He might have had some aortic valve abnormality, which might have resulted in his mild to low moderate aortic regurgitation.
Yes.
It has nothing to do with the coronary artery fistula to the coronary sinus.
Sir?
Okay, yes. What is your doubt?
Sir, in AR, during the release phase of Valsalva, after 7 to 8 weeks, there will be more blood coming to the LV. So LV EDP will be high. So AR murmur should decrease, sir, or whether it will increase.
Because see, the pressure in the aorta is so high that the mild increase in the LV EDP may not have any influence. Okay. So the volume will give rise to still an increase in the air murmur.
Okay, sir.
Any other doubts? Anybody wants to clear any point? Okay, I think that's fine. Good. I think you should know now about the continuous murmur, how to diagnose the exact, the basic pathology when you hear a continuous murmur. and the various mechanisms of production of the continuous murmur. Next class, I think we'll go for few spotters. Will be a spotter session to next class, where I'll bring spotters, which is X-ray, ECG, echo, hemodynamic data, angiogram. All those things will be shown. We'll have about 16 to 20 spotters. Okay, right. Good night. All right.
Thank you so much.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Okay, Aarti, I think you can stop recording. Aarti, are you there?
So thank you everyone. From here now, I'm ending the meeting.